Greetings. This is a replica of my talk given at CSI last year, which was held at Lucknow. The topic is entrainment for VT mapping, and the objectives of the talk are to discuss what entrainment is, when to use it, certain examples, and its pitfalls. So, whenever there is a suspected reentrant tachycardia, it has what is called an orthodromic wavefront and an antidromic wavefront. The antidromic wavefront essentially activates the entire myocardium if allowed, and then there is the orthodromic wavefront that passes through the entire circuit of the arrhythmia or the reentrant circuit, so as to say, and exits into the myocardium. Entrainment is a complex phenomenon that discusses the various occurrences that happen when one paces at a particular site in the myocardium, whether in the circuit or outside the circuit, and based upon the interaction, allows one to understand what that site means to the circuit that has been responsible for the arrhythmia. It also gives us an idea as to what the mechanism of arrhythmia is. Focal arrhythmias cannot be entrained. They can be overdrive paced, but progressive entrainment is usually not present in focal arrhythmias. Again, this particular maneuver is subject to the limitations of the local myocardial response to varying cycle lengths and the output that is delivered at that particular site. So, when you pace in an arrhythmia that is suspected to be reentrant from a particular site, there is set up a wavefront that collides with the wavefront exiting from the circuit responsible for the arrhythmia. As a result, based upon the cycle length of these two wavefronts, you get a fused exiting wavefront that is responsible for the arrhythmia during or for the QRS morphology during this pacing. Now, when we are able to enter into the arrhythmia circuit via this continuous pacing and both fuse with the existing wavefront as well as give rise to a wavefront that traverses the circuit of the arrhythmia under investigation, we get resetting of this particular arrhythmia. By resetting, we merely mean to say that we are able to enter into the arrhythmia circuit, increase the cycle length of the resultant myocardial depolarization to that of the paced cycle length, not terminate the arrhythmia, have a fused exiting wavefront, and when the pacing stops, the arrhythmia resumes. Criteria for entrainment is that there should be fusion between the two wavefronts. This fusion should be fixed at a particular cycle length. At varying cycle lengths, the fusion should be progressive. There should be more contribution of the paced wavefront to the arrhythmia, to the resultant QRS morphology as the pacing cycle length decreases. The tachycardia should continue after cessation of pacing. And finally, the last beat prior to the resumption of the arrhythmia should be paced and not fused. This is because we shall be entering within the circuit and the last beat does not have an antidromic wavefront to fuse with. There is a difference between concealed entrainment and concealed fusion. When we speak about concealed entrainment, we are talking about the pacing, resultant morphology of the QRS, whereas in concealed fusion, it's essentially the tachycardia that we are talking about. There are a bunch of responses to pacing that happen when we try to do these maneuvers during reentrant arrhythmias. Resetting and entrainment are two of the most common and desirable phenomena to occur. However, the tachycardia can terminate, the tachycardia could change, the tachycardia could stop and then restart, it could be suppressed or it could be accelerated. For re-entry, resetting and entrainment are something that are important to be documented to confirm the mechanism. Resetting happens with a single beat or a single extra stimulus, whereas entrainment is based on continuous pacing. Let's take a look at this tracing. As you can see, there is a wide complex tachycardia which is ongoing. The RV catheter is being used to pace at a cycle length which is slightly lesser than the tachycardia cycle length. There is capture of the myocardium as evidenced by the stimulus artifact and pulling in of the local EGM on the RV catheter. The morphology of the QRS during pacing is different than the morphology of the QRS during the arrhythmia, and the tachycardia continues after the pacing has stopped. Short of documenting progressive change in the QRS with varying cycle lengths, it is safe to say that there has been entrainment of this particular wide complex tachycardia. Now that we have ensured that we have entrained this arrhythmia successfully, the measurements that are important include the post-pacing interval, that is the time between the pacing spike and the resultant EGM after the pacing has stopped on the catheter where it was being paced from, this interval. Then the time between the stimulus and the resultant QRS compared to the time between the local EGM and the QRS in the arrhythmia. We also talk about the morphology of the QRS during pacing and the morphology of the QRS during the arrhythmia. Various combinations of these intervals help us understand where within the circuit or outside the circuit of the arrhythmia that particular pacing point is located. So, looking at this particular tracing, we see that the post-pacing interval is 400 milliseconds, whereas the arrhythmia cycle length is 340 milliseconds, thereby suggesting that the site from which pacing is occurring takes a longer time for the pacing wavefront to enter the circuit, and when it stops, for the arrhythmia wavefront to come to the site of pacing. Therefore, we seem to think that this site is not within the circuit of the arrhythmia. Furthermore, the surface QRS morphology is not the same during the arrhythmia as compared to during the pacing. They are close, but they are not entirely the same, leading us to believe that this is a site that is nowhere near the tachycardia circuit and is a site fairly distant away from the arrhythmia circuit. This is an important maneuver to perform because pacing at various cycle lengths from this site would help us understand whether there is entrainment or there is overdrive suppression. The way to understand that is to change the cycle length at the time of pacing, look for progressive fusion, and see if the criteria for entrainment are fulfilled. If there is no fusion or progressive fusion, it just means that the single focal depolarization site responsible for the arrhythmia is merely being suppressed by the increasing cycle length of pacing from this local site. Whereas if it is a reentrant arrhythmia, there would be progressive change in the QRS morphology called as progressive fusion, which is a mix between the QRS which is present in the arrhythmia and the QRS which is derived from pacing at the site from which pacing has happened. So it's a fusion between those two, and this actually helps us understand that it is a reentrant circuit we are dealing with. Now, the protocol for entrainment is usually synchronous pacing to the QRS of the arrhythmia, close to the tachycardia cycle length, usually starting at 20 milliseconds less than the tachycardia cycle length, followed by a decrease, and approximately 10 beats at a time. Pacing output is twice the diastolic threshold. We need to check the threshold in the absence of the arrhythmia and avoid large virtual electrodes by use of large tipped catheters for doing this maneuver. Using these large electrodes might capture tissue well beyond the local area on which the catheter rests, and using larger pacing outputs might capture areas well beyond the contact of the local electrode. So let's come to an example where we look at an arrhythmia which is present on to the right of the screen, where it's a wide complex tachycardia, and we can actually towards the left of the screen make out these pacing spikes, which seem to suggest that there is pacing at the left of the tracing and no pacing on the right of the tracing. Looking at the QRS morphology, it seems that the pacing has captured the local myocardium and has been able to influence how the QRS looks during the arrhythmia. There are minor changes that can be seen in the QRS morphology, especially in leads V4 and V5, suggesting that while this may be very close to the morphology of the QRS during the arrhythmia, it's not a complete match. Looking at the intracardiacs, we can confirm the finding that there was myocardial capture, resulting in the QRS looking the way it is. There is acceleration of the tachycardia to the cycle length of the pacing. And if we look at the intervals we discussed earlier, The post-pacing interval is less than 30 milliseconds. The stimulus to the QRS is similar to the EGM to the QRS, which is 60 milliseconds. This seems to suggest that the site where this particular pacing is being performed seems to be at the entrance of the circuit to the protected circuit responsible for the arrhythmia. The reason why I am saying this is because although the post-pacing interval is 30 milliseconds, the QRS is slightly different and the stimulus to the QRS is just around 60 milliseconds. This is probably suggestive that the pacing site is allowing antidromic capture of the myocardium and the particular wavefront is not being captured by the orthodromic wavefront going inside the circuit or the protected isthmus. Therefore, this is in the outer loop of the protected circuit of the arrhythmia. Coming to a second tracing, if you can take a look at this, this is an ongoing wide complex tachycardia. The site of pacing seems to have two complex signals. The tachycardia is fairly stable in its cycle length, and these signals are consistently present, suggestive that perhaps they are true signals and not mere artifacts. Which one of these is the local signal and which one of these is a signal at distance, or whether these are two signals at the same site remains to be seen. Pacing from this site, which is an endocardial site, for the tachycardia at cycle length of 345 milliseconds, results in a QRS, results in immediate capture of the myocardium. The QRS morphology from this capture seems to be similar in all leads to the QRS of the tachycardia, and when we look at the EGMs that were captured, it is the larger EGM that seems to have been captured and not the smaller one. Now, the post-pacing interval is just 20 milliseconds, suggesting that perhaps this is a site within the circuit of the arrhythmia. The stimulus to QRS is 87% of the tachycardia cycle length. Pay attention that the last paced beat is not this one, but in fact is this. You can actually make that out by looking at the cycle length of the arrhythmia or the pacing on the RV catheter, where the pacing cycle length is 310 and the last coupled paced beat at 310 milliseconds is this QRS. So this particular stimulus artifact gives rise to a QRS at a distance which is 87% of the tachycardia cycle length. The difference between the stimulus to the QRS and the local EGM to the QRS is 10 milliseconds, suggesting that this is probably a very important site within the tachycardia circuit. This site is most likely to be within the isthmus of the tachycardia circuit, because there is a long time that it would take to exit. It cannot exit laterally. The morphology of the QRS from the exit side during pacing would be similar to that during the tachycardia, and the stimulus to the QRS would be similar to the local EGM recorded at this site to the QRS. Very interesting that it was the larger signal that was captured, allowing us to understand that, or perhaps deduce that this is the local signal rather than this signal which is in the mid diastolic location. Mapping the tachycardia further onto the opposite epicardial location of this site showed us that now the signal which was present in the mid diastolic time of the endocardial location or site of recording has now become near field, telling us that perhaps this signal was being recorded on the endocardial site as a small far field signal. This again brings our attention to the large antenna that is our mapping catheters, and why it is important to delineate the local signal prior to making any measurements. Tachycardia is ongoing, cycle length is stable. We proceed to look at the stimulus, rather the local EGM to the QRS during tachycardia, the interval which is around 175 milliseconds, which again is quite large. And we pace at this site. At first sight, what we can notice that perhaps there looks to be what is non-capture, but on closer interrogation of the intracardiac EGMs, one can note that there is indeed acceleration of the tachycardia circuit to the pacing cycle length, and it is in fact the long stimulus to QRS that gives us this impression. Again, just like the previous site, this is a site within the protected isthmus of the tachycardia circuit. The post-pacing, the last QRS derived from the pacing stimulus is this, and you can see resumption of the tachycardia once the pacing has been stopped. In fact, the PPI minus TCL at this site is 0, and the stimulus to QRS is nearly 50% of the tachycardia cycle length, suggesting that the time taken to traverse between the site of pacing and the formation of the QRS resultant from that pacing location is nearly 50% of the entire cycle length of the tachycardia. This again seems to suggest that we are within a protected isthmus of the tachycardia circuit, and like the previous site, the QRS again is going to be extremely similar since it follows a protected channel to exit into the larger myocardium. You can see that we had two sites, one in the endocardium and one in the epicardium, which gave us nearly similar entrainment outcomes, again reinforcing the fact that tachycardia circuits could be three-dimensional and they necessarily need not be only endocardial or only epicardial. Now, since we are all very excited to search for better sites, take a look at this EGM, which was very close to the previous demonstrated site, close in location on the epicardial surface, where a complex fractionated EGM was present, and on the proximal catheter you can see a double signal or perhaps a slightly more complex signal noted there. Again, the tachycardia cycle length is fairly stable. The stimulus to the QRS has now narrowed, And when pacing from this site, you can see there is capture of the myocardium. The QRS looks fairly similar, including the notching in lead AVL. And there is capture of the local EGM at this site. What part of the local EGM is captured remains open to discussion because the stimulus artifact causes signal to be masked within the same. But looking at the intervals, we can see that there has been acceleration to the tachycardia cycle length. The stimulus to the QRS is near immediate as compared to the previous two sites. And it is similar, however, to the local EGM to the QRS that is present. The PPI minus the TCL at this location is again 0 milliseconds, suggesting that it is closer to the exit than the previous two sites, but within the same circuit of the tachycardia, or within the protected isthmus of the tachycardia. So this is closer to the exit than the previous two sites, and as evidenced by the QRS, the larger myocardium is being depolarized with a morphology or in a pattern similar to how the tachycardia would have depolarized the myocardium. Now, let me bring your attention to another tracing where again you have the tachycardia going on, wide complex tachycardia, AV dissociation, likely ventricular arrhythmia. The ablation catheter is placed at a site which has got two signals, one a larger far field and perhaps the second a local signal which is near field and fractionated. Now this signal is close to 42 milliseconds in width, suggestive of a site that is extremely slow in its depolarization and where annotation of this signal might be very difficult. Entrainment from this site suggests a QRS which is similar to the QRS of the tachycardia. There is a similar stimulus to QRS timing, and the post-pacing interval, however, is extremely long as compared to that of the tachycardia. So, this is suggestive of a site that exits into the myocardium at the same location as that of the tachycardia, but is not crucial for the perpetuation of the tachycardia. This is by definition a bystander site where the exit from pacing from that site or exit of a depolarizing impulse from that site is the same as that of the protected circuit responsible for the arrhythmia, but that site per se does not contribute to the maintenance of the tachycardia. Going into another site where the VT cycle, this is a wide complex arrhythmia, probably VT, cycle length of 360 milliseconds with a QRS duration of 156 milliseconds. If you look at the QRS, there is nice slurring of the QRS that you can see, which can be documented again, similar onto the intracardiac tracings. There is capture locally of the EGM during pacing, and one can notice that the QRS morphology is very slightly different from that of the tachycardia that is ongoing. The variations are prominently seen in lead V3 and lead V4. And if we look at the numbers or the intervals post-pacing, we can see that although the PPI minus TCL is less than 30 milliseconds for the tachycardia and the post-pacing interval, The QRS is not the same, which again brings us back to the first tracing that we saw, that this is a site which is present at the entry to the circuit of the arrhythmia, and although has a PPI minus TCL which is similar to that of which has a post-pacing interval that is similar to the tachycardia cycle length, it depolarizes the myocardium without entering the tachycardia isthmus or the tachycardia circuit. It is able to capture the entire myocardium antidromically and without entering orthodromically into the circuit of the arrhythmia. This, as I mentioned previously, is an outer loop which, although is a part of the circuit of the arrhythmia, but it can actually give you a QRS morphology different from that of the tachycardia QRS morphology. What's very critical to understand as we do these maneuvers in the lab is that entrainment has its limitations. Sometimes when we pace closer to the tachycardia cycle length, the tachycardia may terminate. Therefore, pacing it extremely close to the tachycardia cycle length is probably required. There is no measure of local tissue velocity at cycle lengths that we are pacing. So our measurements may be thrown off by delay within the tissue from where we are pacing. In the tissue that we are activating, we do not understand the decrement characteristics. The tachycardia can actually be captured antidromically, as we documented in the last tracing, wherein we need to reposition the catheter slightly or decrease the output to prevent that. We use large electrode tips for capture of the myocardium, and it's not a true local capture that happens. It's a capture probably over a varying area of myocardium. This maneuver is useful when a single monomorphic arrhythmia is present. Sometimes the tachycardia may change morphologies during entrainment, or if the tachycardia is pleomorphic, this particular maneuver cannot be used. It is important that the patient tolerates the arrhythmia hemodynamically. In the absence of that, we may not be able to perform this maneuver. Sometimes, while pacing from a particular point, the wavefront may find it extremely difficult to enter into the circuit of the arrhythmia. We may have to change the wavefront in order for the circuit to be entrained. We may not be able to synchronize to the local EGM. We may have to use a different pacing bipole in order to be able to synchronize appropriately. At the pacing site itself, because the stimulus artifact may cause concealment of the local stimulus EGM, it's very difficult to figure out what is local and what is at distance. So also may be difficult to understand whether the local EGM has been captured. We may have to use surrogate measures like measuring the cycle length of an electrode placed elsewhere to see if the tachycardia cycle length has been accelerated to confirm capture. Unipolar pacing can help, but because of the large artifact, it usually causes problems. The capture latency, namely owing to the time required to capture tissue in scarred tissue, may cause issues with measuring intervals in the circuit. We may have to reposition the catheter slightly or clock it to actually get a change in the way the tissue is being captured. And sometimes the local threshold itself within a scar is very high, and so we may have to increase the output or use a smaller electrode with higher charge density to be able to capture the tissue. In summary, therefore, entrainment is not all encompassing. It is actually a paradigm within the construct that tissue velocity is constant, non-decremental, and the tissue captured is local tissue. It can detect potential sites which are within the tachycardia circuit, including the isthmus of the tachycardia circuit, the entry site, the exit site, and bystander site. The limitations, as mentioned above, need to always be taken into account. And finally, although it is an exciting maneuver to perform, but in the absence of colleagues who are trained to perform and interpret this maneuver, entrainment is certainly not entertainment. Thank you for your patient listening. Do send in your questions, if any.